Welcome to our video on renal indices. After watching this video, you are expected to know the following concepts: renal blood flow, renal plasma flow, glomerular filtration rate, filtered load of a solute, filtration fraction, and fractional excretion of a solute. You are also expected to be able to calculate estimated glomerular filtration rate based on creatinine clearance, clearance of any solute, filtration fraction of renal plasma flow, renal blood flow given renal plasma flow and hematocrit, or vice versa, and fractional excretion of sodium or any solute of interest. Before we dive into renal indices, let's define a couple of terms. This is whole blood in a test tube. When we centrifuge whole blood without allowing it to clot, all the blood cells settle and pack at the bottom of the tube. The proportion of blood containing only packed red cells is called hematocrit. Normal hematocrit level is approximately 40 to 45% of whole blood volume, or if expressed in fraction, it is 0.4 to 0.45. Patients who have anemia have a low number of red blood cells, thus a lower hematocrit level. The cell-free fluid in the blood is called plasma. The fraction of plasma volume in the blood is 1 minus hematocrit. Imagine a patient with a hematocrit of 45%. The plasma proportion in whole blood is 1 minus 0.45, which is equal to 0.55 of the whole blood volume. The plasma volume for any given whole blood volume for this patient would be 0.55 times that blood volume. Basic terms. Renal blood flow refers to whole blood flow that originates at the renal artery and drains into the venous circulation via the renal vein. Renal blood flow comprises roughly 20% of the total cardiac output. This is approximately 1 liter per minute. Renal plasma flow refers to the flow of the cell-free plasma volume through the kidneys. Renal plasma flow more directly and accurately determines solute clearance than renal blood flow, because solutes that are cleared by the kidneys have to be free in the plasma. Glomerular filtration rate, or GFR, is the rate of the plasma that gets filtered at the glomeruli. Once filtered into the urinary collecting system, solutes may be reabsorbed by renal tubules. Solutes within the plasma that have not been filtered may also be secreted from peritubular capillaries into renal tubules. The final concentration in the urine of any solute depends on how well it is filtered at the glomeruli and reabsorbed or secreted by renal tubules. Filtration fraction is the amount of renal plasma flow that gets filtered across the glomeruli. Mathematically, filtration fraction is glomerular filtration rate divided by renal plasma flow rate. Filtration fraction is about 20%, which indicates the remaining 80% of renal plasma flow continues its pathway through the rest of the renal circulation. One by one, we will discuss how we measure renal blood flow, renal plasma flow, glomerular filtration rate, and filtration fraction. Let's first discuss glomerular filtration rate, commonly abbreviated as GFR. Clinically, GFR is used to assess kidney function. Normal GFR has a wide range, but on average, we can approximate it as 100 ml per minute. Low GFR indicates poor kidney function or renal hypoperfusion due to low blood flow to the kidneys for whatever reason, while super high levels indicate hyperfiltrative states, commonly seen in patients with diabetes mellitus or pregnancy. Here we have a glomerular capillary filtering plasma and its solutes into the urinary collecting system. How do we measure glomerular filtration rate? If we know the concentration of a particular solute in the plasma, and we can count how much of this solute ends up in the urine, we can calculate the volume of the plasma that was just filtered. The trick is to follow a solute that is easily filtered and not protein bound, otherwise it cannot be freely filtered. Additionally, this solute has to be neither reabsorbed nor secreted by tubules, because we are only interested in knowing how much of the solutes get excreted into the urine from glomerular filtration alone, not from tubular secretion or affected by tubular reabsorption. In our cartoon here, if we count the number of solutes excreted into the urine, the red ones come from glomerular filtration, minus some that have been reabsorbed by renal tubules. The yellow ones come from both glomerular filtration and tubular secretion. The best solutes to follow to measure glomerular filtration rate alone are the blue ones. These are not protein bound, they are easily filtered, and they are neither reabsorbed nor secreted by renal tubules. So let's go look for the perfect blue solute in real life. In the search for the perfect solute to measure glomerular filtration rate, we come across a molecule called inulin, not to be confused with insulin. Inulin is a naturally occurring polysaccharide that is non-toxic. It is not protein-bound in the plasma. It is freely filtered across the glomerular basement membrane, and it is neither secreted nor reabsorbed by renal tubules. Here is our glomerulus. Let's inject inulin into our patient to achieve a good constant plasma inulin concentration. The inulin then goes to the glomeruli for filtration. We then collect the urine and measure how much inulin has been cleared by glomerular filtration and ends up in our urine collection. Our assumption is everything that is filtered by the glomeruli, that is, cleared from the plasma by glomerular filtration, ends up in the urine collection bucket. The total rate of inulin that is filtered is equal to the plasma concentration of inulin times the GFR. The rate of inulin excreted into our urine bucket is the urine concentration of inulin times the urine output rate. What's filtered ends up in the urine. That's why the equal sign. Here we have our equation. Plasma inulin concentration times GFR is equal to urine concentration of inulin times urine output rate. Solving for GFR, we have GFR as urine inulin concentration times urine output rate divided by plasma inulin concentration, which is equal to U times V over P, where U and P are concentrations of inulin in the urine and plasma respectively, and V is the urine output rate. To summarize, inulin is a molecule that is freely filtered by the glomeruli. It is neither reabsorbed nor secreted by renal tubules. Inulin clearance may be measured to estimate glomerular filtration rate, where GFR is approximately equal to UV over P of inulin. Of note, UV over P is not just used for the calculation of inulin clearance and GFR. We can actually use the expression UV over P to calculate the clearance of any solute of interest. That is, the clearance of solute A is UV over P of solute A, where UA is the concentration of solute A in the urine, V is the urine output rate, and PA is the concentration of solute A in the plasma. However, when we use this equation to calculate the clearance of any solute other than inulin, it should be noted that the calculated clearance value does not tell us if the solute is cleared by glomerular filtration alone, glomerular filtration plus tubular secretion, or glomerular filtration minus tubular reabsorption. It just tells us the rate of clearance for the solute of interest. It is cumbersome and costly to inject patients with inulin to measure GFR. Lucky us, we do have a naturally made compound in our body, free of cost, that we can use to calculate GFR. This molecule is called creatinine. Creatinine comes from normal muscle metabolism. It is released at a relatively constant rate of 15 to 25 mg per kg per day. Higher values are seen in individuals with bigger muscle mass. Individuals with normal kidney function have stable creatinine plasma level at the range of 0.6 to 1.2 mg per deciliter. Creatinine is not protein-bound in the plasma. It is freely filtered at the glomerular basement membrane and not reabsorbed by renal tubules. However, 5 to 10% of creatinine is secreted by proximal renal tubules. Because of this, when we use creatinine to calculate GFR, we can overestimate the true GFR. Now we can estimate GFR based on the calculation of creatinine clearance. As shown here, creatinine clearance is equal to UV over P, where U is the urine concentration of creatinine, V is the urine output rate, and P is the plasma concentration of creatinine. We typically collect the urine volume over 24 hours. To get the urine output rate as ml per minute, we just divide the urine volume in ml over the number of minutes per day, which is 1,440 minutes. Example: consider a 24-hour urine collection where urine creatinine concentration is 87 mg per deciliter. Total urine volume is 1,700 ml, which translates to a urine output rate of 1.18 ml per minute, and plasma creatinine concentration of 0.8 mg per deciliter. Our estimated GFR based on creatinine clearance is 87 times 1.18 divided by 0.8, or 128 ml per minute. Again, it is important to understand that the GFR estimated by creatinine clearance is greater than the true GFR because of tubular secretion of creatinine into the urine. We count all the creatinine in the urine bucket as if they all come from glomerular filtration, but some creatinine actually come from tubular secretion. This is why creatinine clearance overestimates true GFR. Note the following caveats in using plasma creatinine and creatinine clearance to estimate GFR. Creatinine level varies with age, muscle mass, and protein intake. Patients with bigger muscle mass or higher protein intake can have higher plasma creatinine level, thus perceived lower GFR. Remember, creatinine clearance is inversely proportional to plasma creatinine level. In contrast, lower plasma creatinine level observed in patients with advanced liver disease overestimates GFR. Creatine, the precursor of creatinine, is made in the liver. This level is reduced in patients with advanced liver disease. Inhibitors of tubular creatinine secretion, such as keto acids, and drugs such as cimetidine and trimethoprim, can result in higher plasma creatinine level, thus perceived lower GFR. Again, this is because creatinine clearance is inversely proportional to plasma creatinine level. Since daily endogenous creatinine production is fairly constant, daily urinary creatinine excretion remains fairly constant. On average, creatinine excretion is approximately 20 mg per kg body weight per day. Example: for Mr. A weighing 70 kg, 24-hour urine creatinine excretion is expected to be approximately 20 times 70, which is 1,400 mg of creatinine per day. Let's say we have a forgetful Mr. A who turns in a 24-hour urine collection for you to assess dietary sodium adherence. You have instructed him to restrict his daily sodium intake to 100 millimoles per day. His urine collection shows a total creatinine of 3,000 milligrams and total sodium content of 200 millimoles. Did Mr. A adhere to his low sodium diet? The total creatinine level in his 24-hour urine collection is 3,000 milligrams instead of 1,400 milligrams as expected. The total sodium in the urine collection is 200 millimoles. The higher total creatinine amount in the urine than expected suggests that Mr. A likely forgot his time and day and overcollected the urine. The 200 millimoles of sodium is likely an overestimate of Mr. A's actual daily sodium intake. This means you cannot accuse Mr. A of being non-compliant to his daily dietary sodium restriction. Now Mr. A comes back with another urine collection, where the urine collection only has 700 milligrams of creatinine. The total sodium content is 100 millimoles. Did Mr. A adhere to his low sodium diet? Mr. A likely undercollected the urine in this case because there's only 700 milligrams of creatinine in the urine instead of the expected 1400 milligrams. The total 100 millimoles of sodium may be misleading. At a glance, you may think that Mr. A is compliant with a low sodium diet, but you should know better that the total sodium content likely represents only half of what Mr. A really consumed because the urine collection is inadequate. Bottom line, whenever a 24-hour urine collection is ordered to measure the clearance of any substance, creatinine should be included to assess 24-hour urine collection adequacy for accurate interpretation. Limitation to using plasma creatinine to estimate GFR. Creatinine is actually not very sensitive in detecting small changes in GFR. As shown here, GFR, shown on the x-axis, is inversely proportional to plasma creatinine concentration, shown on the y-axis. The inverse relationship between plasma creatinine and GFR makes it difficult to detect small changes in GFR. A small change in creatinine can mean a big change in GFR. For example, for a patient to have a creatinine increase from 1 to 2, the GFR has already declined from 100 ml per minute plus to 50 to 60-ish ml per minute. Relying on the serum creatinine for GFR change can miss the detection of small changes in GFR, thus the chance to promptly treat any underlying injury to the kidney before it is too late. Blood urea nitrogen, or BUN, may also be used to estimate GFR. Similar to creatinine, BUN levels vary inversely with GFR. Similar to creatinine, using BUN to estimate GFR also has limitations. Urea production is not constant. BUN production is increased with protein intake and/or bleeding. It is decreased in patients with liver disease and/or malnutrition. BUN is filtered and reabsorbed. This means that if we estimate our GFR based on urea clearance, the GFR will be underestimated. Recall that the use of creatinine clearance overestimates GFR. In the past, we often just average creatinine clearance and urea clearance and use the average value as a relatively better estimate of GFR. Facts about BUN that are important clinically. Urea clearance falls out of proportion to the fall in creatinine clearance in patients with poor renal perfusion and volume depletion. This means blood urea nitrogen levels can rise out of proportion to plasma creatinine levels. Because of the disproportionate increase in BUN and creatinine levels, increased BUN to creatinine ratios greater than 20 typically suggest reduced renal perfusion. Conditions are associated with increased urea production or catabolism, including gastrointestinal bleed, and the use of glucocorticoids can also give rise to high BUN to creatinine ratios. In addition to inulin, creatinine, and BUN, we have other biomarkers that may be used clinically to estimate GFR. These include radiolabeled filtration markers, including chromium, EDTA, iothalamate, and technetium. We may also use cystatin C. Cystatin C is produced by all nucleated cells in the body. It is less dependent on age, sex, race, and muscle mass. However, it may be influenced by HIV, the presence of C-reactive proteins, pregnancy, smoking, malignancy, thyroid disorders, and glucocorticoid therapy. Cystatin may be used more often in patients with advanced liver disease. Over the years, numerous formulas have been derived to estimate GFR to avoid the cumbersome need for collecting 24-hour urine collections to calculate creatinine clearance or urea clearance. These formulas include the Cockcroft-Gault MGRD 4 and 6 variable equations and CKD-FB. Most equations are based on the measurement of serum creatinine, age, and gender. Since creatinine depends on muscle mass, and muscle mass may vary depending on body build and ethnicity, some equations take ethnicity into account. In fact, GFR equations have been derived for different populations in Europe, China, Japan, and perhaps others. Some equations have included the measurement of cystatin. Currently, the most commonly used equation clinically is the CKD-FB equation. Most clinical labs now automatically report an estimated GFR whenever a serum creatinine is measured. We have now discussed GFR and solute clearance. We're now going to shift our focus to the measurements of other clinically relevant parameters for the kidneys. We are going to start with renal plasma flow and renal blood flow. So how do we measure renal plasma flow rate? There is a non-toxic water-soluble molecule called para-aminohippuric acid, or PAH, that can be used to measure renal plasma flow. PAH can be infused into a patient to achieve a constant plasma concentration. What we know is that PAH that passes through the kidneys via renal plasma flow either gets filtered by the glomeruli, or if the PAH escapes glomerular filtration, gets secreted by proximal tubules before the plasma flow returns to the renal vein. A single pass of renal plasma through the kidneys essentially clears on average 90% of PAH. What this means is the effective renal plasma flow rate closely reflects the rate of PAH clearance from the kidneys, where clearance of PAH is UV over P of PAH. Since PAH clearance is not quite 100% with a single pass of renal plasma flow, effective renal plasma flow as measured by PAH clearance is slightly underestimated. How do we calculate renal blood flow from renal plasma flow? Recall that plasma volume is whole blood volume times the quantity 1 minus hematocrit. From here, we can solve for renal blood flow, which is renal plasma flow divided by the quantity of 1 minus hematocrit. We have another index called filtration fraction. It is basically the proportion of renal plasma flow that gets filtered by the glomeruli. Filtration fraction is therefore just GFR over renal plasma flow. In normal kidneys, filtration fraction is approximately 20%. How do changes in glomerular filtration rate and renal plasma flow affect filtration fraction? Let's stretch out our renal arteriole with renal plasma flow as shown. Some of the renal plasma flow gets filtered through the glomerulus. The glomerular filtration is regulated by blood inflow and the vascular tone of afferent and efferent arterioles. Filtration fraction is the fraction of total renal plasma flow that is filtered through the glomerulus. Filtration fraction is essentially glomerular filtration rate divided by renal plasma flow. What happens to the filtration fraction when there is afferent arteriolar vasoconstriction? Renal plasma flow will decrease, and so will glomerular filtration. As both the numerator and the denominator are decreased, the filtration fraction will be relatively constant. What happens to the filtration fraction when there is efferent arteriolar vasoconstriction? Renal plasma flow will decrease, but glomerular filtration will increase. As the numerator GFR is increased and the denominator renal plasma flow is decreased, the filtration fraction will be increased. How do changes in plasma protein concentration affect filtration fraction? What happens when there is an increase in plasma protein concentration? The increase in intraglomerular oncotic pressure due to the higher plasma protein concentration will reduce net glomerular filtration while the renal plasma flow remains unchanged. Because the numerator GFR is decreased and the denominator renal plasma flow is relatively unchanged, the filtration fraction will be decreased. What happens to the filtration fraction when there is a decrease in plasma protein concentration? The decrease in intraglomerular oncotic pressure due to the lower plasma protein concentration will favor glomerular filtration, but it will not affect renal plasma flow. Because the numerator GFR is increased and the denominator renal plasma flow is relatively unchanged, the filtration fraction will be increased. What happens to the filtration fraction when there is a urinary obstruction with increased hydraulic pressure from the urinary collecting system? Glomerular filtration rate will be decreased, but renal plasma flow remains unchanged. As the numerator GFR is decreased and the denominator renal plasma flow is relatively unchanged, the filtration fraction will be decreased. Finally, what happens to the filtration fraction when there is volume depletion? Both the glomerular filtration rate and renal plasma flow will be decreased. However, the reduced glomerular filtration will activate the renin-angiotensin system to cause efferent arteriolar vasoconstriction to increase glomerular filtration rate. Because of this compensatory mechanism, the GFR is only partially reduced relative to the reduced renal plasma flow with volume depletion. As the numerator GFR is only partially decreased relative to the more reduced renal plasma flow in the denominator, the filtration fraction will be increased. We are on the home stretch. Other indices to know. Filtered load of solute A is equal to GFR times the plasma concentration of solute A. Excretion rate of solute A is equal to urine output rate times the urine concentration of solute A. Excretion of solute A is equal to filtration plus tubular secretion minus tubular reabsorption of solute A. We have a clinically very useful index called fractional excretion of a solute. This is basically how much of a filtered load of a solute ends up getting excreted into the urine. Let's go over how we can calculate the fractional excretion of a solute. Again, the fractional excretion of a solute means how much of the filtered load of the solute is actually excreted into the urine. Just because a solute is filtered does not mean that it is all going to end up in the urine. This is because renal tubules can reabsorb, secrete, or both for a given solute. The filtered load of a specific solute, let's call solute A, is the total amount of solute that is being filtered. The filtered load is equal to the rate of glomerular filtration times the concentration of the solute in the plasma. The amount of solute A that is excreted is the urine output rate times the concentration of solute A in the urine. As we previously discussed, GFR can be estimated by creatinine clearance, or UV over P of creatinine, where U is the urine concentration of creatinine and P is the plasma concentration of creatinine and V is the urine output rate. The fractional excretion of solute A is the amount of solute A that is excreted over the filtered load of solute A. This is the equation for the fractional excretion of solute A. We simplify the equation and cancel out the V in the numerator and denominator and move the plasma creatinine up to the numerator. The fractional excretion of solute A becomes plasma concentration of creatinine times urine concentration of solute A divided by urine concentration of creatinine times plasma concentration of solute A. So how do we interpret and use fractional excretion of a solute? Example 1. If a given solute has a fractional excretion of 1, it most likely means that all the solutes that get filtered end up in the urine collection, and that there is no tubular reabsorption or secretion. Although it could be argued that tubular reabsorption equals tubular secretion for this particular solute. Example 2. PAH is both filtered and secreted by renal tubules. What would the fractional excretion of PAH be? It is likely going to be greater than 1. Example 3. For sodium, we have a high filtered load, but sodium gets reabsorbed everywhere along the nephron. The fractional excretion of sodium is generally less than 1. In patients with volume depletion or poor renal perfusion, renal tubules will work very hard to reabsorb as much sodium as possible. For this reason, the fractional excretion of sodium, typically referred to as FeNA, would be much less than 1. When FeNA is greater than 1 in these cases, it can be assumed that there has been extensive tubular injury or necrosis that has led to tubular failure to reabsorb sodium as needed. Here are a few questions to test your knowledge. Pause the video to answer the following questions. Once done, resume the video for answers. First question. What happens to the estimated glomerular filtration rate if you assume it is equivalent to the clearance of a solute that is filtered by the glomeruli but also reabsorbed by renal tubules? The GFR will be underestimated because some of the filtered solute get reabsorbed and do not end up in the urine collection that is used to calculate clearance. Second question. For a 60 kg patient with the following blood chemistry and 24-hour urine collection. A. What is the estimated GFR based on creatinine clearance? Calculate creatinine clearance. So creatinine clearance is UV over P of creatinine, which is urine creatinine concentration of 67 times urine output rate of 1.18 ml per minute divided by plasma concentration of creatinine of 3.2. This is equal to 24.7. B. What is the filtered load of sodium per minute? The filtered load of a solute is the glomerular filtration rate, or GFR, times its concentration in the plasma. Plugging in the numbers, we have GFR of 24.7 ml per minute above, times plasma sodium concentration of 135 millimoles per liter. This turns out to be 3.3 millimole per minute. Note, we have to convert the unit of plasma sodium concentration of millimole per liter to millimole per ml to be consistent with the units of GFR expressed as ml per minute. What is the fractional excretion of sodium, or FeNA? Using our derived formula for FeNA, we get a FeNA of 0.03, or only 3% of filtered sodium actually gets excreted. This means patients' renal tubules are reabsorbing most of the filtered sodium. 97% of filtered sodium is reabsorbed, to be exact. A low FeNA typically indicates that patient has hypovolemia or renal hypoperfusion, and the kidneys are working as hard as they can to hold on as much sodium as possible for the body to prevent worsening of current hypovolemic or renal hypoperfused state. At this time, make sure you can explain renal blood flow, renal plasma flow, glomerular filtration rate, filtered load of a solute, filtration fraction, and fractional excretion of a solute. You should also make sure that you can calculate estimated glomerular filtration rate based on creatinine clearance clearance of any solute, filtration fraction, renal blood flow given renal plasma flow and hematocrit or vice versa, and fractional excretion of sodium or any solute of interest. That's it. Enough renal math for now.